So it's now my great pleasure to introduce our next speaker to you, Professor Andrew Morris. So he's going to address innovation in the fourth industrial age. And if it's okay with you, Andrew, I've been given a brief bio of your very, no, you can stay there, your very impressive career history, which I hadn't realized at all, and went, wow, and he's supporting the NIA. So since August 2017, Andrew has been the inaugural director of Health Data Research UK, and I think you're going to hear a little bit about that shortly. And he's seconded to that role from his position of Professor of Medicine and Vice Principal of Data Science at the University of Edinburgh, where he started there in 2014. Prior to this, he was Dean of Medicine at the University of Dundee, but of course that's not enough, because during 2012 to 2017, he was also the Chief Scientist of the Scottish Government Health Directorate. Wow. He's also chaired and sat on a number of government international grant awarding committees as well. So it is my great pleasure to hand the floor over to you.
Okay. Oh, thank you. Thanks, Tony. What a great day. Congratulations. I remember actually being invited to the launch of this NIA at the Health Foundation. How many years ago was that, Charlie? 3 years ago? And actually it was John Byrne from Newcastle who gave Tony's speech. And he says, look, you guys have got a challenge. The NHS is like a jelly. And you punch it or you try and innovate in it, it wobbles, then it goes back to where it was. And I thought, oh, that's really a challenge. But actually, look at the data, because I'm into data. So this program has been adopted in 1,700 NHS organisations, created 287 jobs, and raised almost £80 million of future funding. So this is terrific. And you are now part of a very important community, which will not only transform healthcare in this country, but globally. And I would ask, which of you will be the first unicorn? Does anyone know what a unicorn is? Everyone's nodding. Are there any unicorns in the room? Sadly not. Not yet. Maybe next year. So a unicorn is a business which turns over $1 billion from technology. Why not? Why not? So what I want to... Oh, I can't even see my own slides. Can we go back? So I want to talk about health data science in the UK. I'm going to have to do this, you see. And the fourth industrial revolution. So definitions are important. So my definition of data science is the interface between mathematics, statistics, computational science, and domain. And our domain is healthcare and biomedical research. So how many mathematicians in the room? Right. How many statisticians? How many computational scientists? An outlier. How many domain experts? Health and social care. Everyone, I guess. So I think the challenge is to see that connectedness. Okay? So next slide. So what I'm going to say is that we should be doing this for the United Kingdom. How can we gear up the UK for quality healthcare research and innovation using data science as a catalyst for change, but also talk about trust? Because if we don't do this without a social contract and citizen and patient leadership, then we won't get there. So I'm delighted that Ashling's here today, who's doing a terrific job with the Association of Medical Research Charities to look at the connectedness with our publics. But before I do that, next slide. Thank you for teeing me up, Tony. The birth of the NHS. Here he is, Nye Bevan in Trafford General Hospital. Some people suggest this is Mrs. Thatcher in the bed, listening very intently. Quite the most ambitious adventure any healthcare system has ever seen. Outlived 14 prime ministers. So that was 1948. Now, in the same year, an innovator, he was a neurologist called Thomas Dorber, was doing something very important in this place. Next slide. Does anyone know where that is? Tony, where's that? There's a clue. You see the flags? Yeah, see the clue? So that's Framingham Town Hall. Framingham's a little village, about 40 miles due west of Boston in Massachusetts. And it was 1948 that Thomas, an innovator, everyone thought he was mad. Next slide. He said, we're going to get citizens and scientists and healthcare providers to do something very special. So he recruited all adult town residents, only 5,000 people, 5,000 people. He subjected them to regular health checks, 3 or 4 generations now, and it's truly iconic. Next slide. Because he coined the phrase risk factor. He measured blood pressure, smoke, cholesterol, diabetes, and the intimate links to heart attacks, strokes, and outcomes. Next slide. And Claude Lafont said, Framingham has resulted in an average of 4 extra years of life from 5,000 people. And we still use these data today. GPs, any GPs in the room? Great. So if I came to see you and you were calculating my primary cardiovascular risk, you would use Framingham data. So that has an innovation that has transformed the world. Next slide. But we're in a new era. And the new era is the 4th industrial revolution. Sometimes I feel I remember the first, which was steam power, through electrification, automation, through the IT revolution, which is what I call the pull revolution. Google's pull, because you pull information. We've transformed that into how we learn and use data, often in real time, in a highly analytical way. And it's very disruptive. It's changing every industry in every country. The rate of change is exponential rather than linear. And this disruption can be corrosive. It can undermine democracy, for example, but it can also be hugely beneficial. And our challenge is, how do we deploy the 4th industrial revolution in a trustworthy way in medicine and healthcare? Because it's coming. Next slide. And where are we now? So Aradazi produced this lovely graph saying, what's the rate of AI adoption and data science in major industries? So as you would expect, out there in the front are fintech, technology companies, and actually health is mid-table. We're like West Ham in terms of how we play. And we're up there with the lawyers and the construction industry. And I would argue, in terms of variation, harm of health systems, in terms of sustainability of health systems, we've got to look at how we harness, how we use data in real time to improve. Next slide. Because this is too busy, this slide, but this was some stuff from Baker in the States. He looked at 12 common features of high-performing health systems. So the usual things, and the long-term plan, Tony, maps on well to this: quality, leadership, system governance. But 2 other issues. If you go to Kaiser, if you go to Geisinger, if you go to Mayo, you see whole system intelligence, often in real time. So I can go to Geisinger and follow patients from primary, secondary, tertiary social care in real time. So those journeys of care are well mapped. And lastly, they invest in research and innovation within the system. And that's why you are so important, because you are within the healthcare system innovating. Next slide. So technology is hitting us. So in medicine, we feel we've made strides, but across the computer science community, whether it's in security, social computation, data architectures, sensors, robotics, there are remarkable strides in computation. And yet we don't really see these technologies deployed reliably and at scale within our health system. What we're also seeing is confluence of these technologies. So when you innovate, try not to be unidimensional. Think about how you can bring in other skills and technologies. Next slide. So why are we doing this? So this is Leroy Hood, who first helped describe the genome. So Leroy says medicine in the future, and I think the long-term plan could be a 4P plan. Predictive, preemptive, personalized, and participatory. Okay, we subscribe to that. Enabled by molecular definition of disease, phenotyping, informatics, analytics, and this new social contract. So that's why you are so important in terms of the 4P future. Some people think it's a 5P future. Actually, a finance director said, Andrew, you're wrong. The 5th P is parsimonious. But there's an important message there. If we just keep adding cost to a system, it's not going to work. So we've got to look at value. Better care, reduce cost. David Blumenthal, formerly president of the IOM, talks about frugal innovation. that you can deploy and actually reduces costs also almost immediately. Next slide. So that's one point. Second point is scale. So this is Framingham I talked about. This is a relationship between blood pressure and mortality from the Framingham study. As I said, that's 5,000 people. Next slide. That's 50,000 people. Next slide. UK Biobank. So we're going to have to think about how we use information and data at scale if we're really going to tease out the clues. Next slide. And to show that for cancer, so this is slightly research-based, but say we wanted to run a trial of 250 new cases of a specific cancer in the UK to see whether a precision medicine worked. Now, when I trained and graduated in 1987, there were 5 types of breast cancer, as defined by microscopic appearance and histopathological staining. There are now 133 different types of cancer based upon the molecular cause. So let's flip that. If you wanted to do an experiment, most of these are at the 1% frequency rate. In lung cancer, you'd need 47 million people to run that study for 250 people. The less common cancers, pancreas, 225 million, and rarer cancers, almost 500 million people. So if we are going to give the precise medicine we want in the future, we need to be able to scale out. Next slide. The other thing which Tony touched upon, this is the UK productivity graph. We've got to look at productivity because we're falling behind, because we haven't automated. We're 18 base points behind the French, 36 points behind the Germans. We are not productive. Innovation is a good way to drive productivity. Next slide. And the other thing is, again, our SME base. This is some great work that Chris Malloy did at the Catapult. Most of these companies which employ jobs in the UK look elsewhere. So about 80% of our companies in the UK think access to data and samples would be really useful. 75% of them have to go out to the UK to access those data. So why can't we pull that together? Next slide. So a few examples of what's potentially coming down the tracks. Sebastian Thrund was head of R&D at Google. He's now a life science researcher. He looked at 130,000 images, photographs of skin lesions. He said, can I differentiate malignant melanoma versus seborrheic keratosis? He could. He outperformed the doctors, and he now wants to put this on a mobile phone. So this is happening. Next slide. This is John Dinesh using blood donors. This is one of my colleagues in Cambridge, looking at the blood donor service. Can we actually discover new biology from routine data? Next slide. Yes, you can. Almost 2,000 molecular signatures from blood donors by linking genomic data with proteomic data we didn't know was there. Next slide. Another one, this is radiography, pediatric pneumonia or diabetic retinopathy. Machine learning of images. And again, hundreds of thousands needed, but they can outperform usual care. Is this important? Yes, it is. Nicholas Strickland, president of the Royal College of Radiologists, tells me today there are 250,000 people waiting for the result of a medical imaging diagnosis. So why can't we sieve out the normals using machines? Next slide. What's this one? Yes, this is to show that health screening not meeting targets. This was just in the BBC a couple of weeks ago. So if we could use machines to actually stratify where we need to use our precious human resource, it'd be good. Next slide. This is a wee story from Scotland. When we have clinical equipoise, why don't we randomise within the health system? So colleagues did it for CT coronary angiography across 12 sites. When I was chief scientist, I funded this. It was a study of 5,000 people. Cost £700,000. Two things. Firstly, when we published it in the Lancet and the New England Journal, it changed care in 25% of patients, CT coronary angiography at admission rather than routine care. Second point is a similar American study cost $47 million. So if the NHS does this well and randomized within a system, it really can drive innovation. Next slide. This is showing how you can use routine data for new biology. This is some work looking at pharmacogenetics. Next slide. And just to give you a sense of the computing power that's downstream, the Gordon Bell Prize is awarded annually, and in November of last year it was awarded to the University of Texas because they analyzed about 1 million genome studies and 1 billion medical records. But they performed 2.36 billion comparisons per second. So this is happening, this is becoming available. How can we unleash data to actually derive new insight rapidly from it? Next slide. Prescribing's a big target. And why aren't we, next slide, using next slide, please. Using prescribing data more judiciously to make healthcare more safe? Next slide. So what are the challenges ahead of this? So one or two. Next slide, please. The first is detail and quality. So this is an interesting story. In the States, they curated 2.1 million patient records for cancer to actually improve patient care and actually add huge value because Roche actually bought this small company. So they were like you 10 years ago. They were small innovators and they sold it for $2.1 billion. But actually this was a mechanical Turk innovation. Does anyone know what a mechanical Turk is? Do you know, Charlie? Correct. It was a wooden box in the 18th century that played chess against Napoleon and Benjamin Franklin, and it won. And everyone thought it was a computer. But actually there was a man in the box pulling the levers, you see. But it shows if you innovate in even from a granular way, you can create huge value. Next slide. Just to illustrate this point, this is Ewan Pearson, my mate. He said, Andrew, this is the top 20 ways we prescribe metformin in the country. And I said, that's very interesting. Next slide. And he said, next slide. This is the bottom 20 ways. Next build, please. So there are 5,000 ways of prescribing metformin alone. So we've got to think about quality, detail, and if you do, you will innovate well. Next slide, tongue in cheek, when we did diabetes in Scotland, because we've got a complete real-time information system for all diabetes in Scotland. Next slide. We focused on quality. Next slide. This was Richie and Janice who did the work. Next slide. Because Richie phoned me up one day, next build, he says, Andrew, I found 10 patients walking around the streets of Edinburgh who, according to the NHS, are dead. So I said, what? He said, what are we going to do? And I said, we'll publish it. So we published their life after death range, and next slide, and the resurrection rate was very healthy. So this detail and quality is going to be very important for you. Next slide. Second big issue is digital maturity of the NHS. Next slide, because I won't dwell on this, because this is some work we did with Charlie and colleagues at UCLP. I'm pleased that Matt Hancock is really pushing on the basics, because we need to get more digitally literate, else you'll never have AI and machine learning unless you get the basics right. So that's important. Next slide. It's a complex environment, and this is what we're working in. So we're interested in interoperability to work across systems with no additional effort. And although we talk about the NHS as a single entity, it's not. And I've provided support for innovators in the past, and most of it was around governance, data access, ethics. It's our job to make your lives easy. And that's, next slide. But I went to Holland recently, it was just as chaotic there. So I think if we can sort out this interoperability, then we'll be doing well. Next slide. And then the last big thing is trust. Are there any members of the public in the room here? That's good, okay. Because that's important. And I hope you've got a place on this podium, because we are all public servants. So how we position this is important. Next slide. And how we use data and innovation for the public interest and good is important. Okay, next slide. So I would suggest that what we need to do is this. If we study, let's assemble our innovation or our data, analyze it, interpret it. But don't forget the efferent loop. So how do we tailor the message and then actually deliver and measure its impact? Because a lot of research, next slide, finishes there and we publish in journals. And that is not very agile. doesn't it? It takes 15 years. So I see your innovation. Think it's not it's the learning of the system. Okay? Have I got 2 minutes or not? How am I doing for time? 2 minutes. Okay, next slide. So I'll canter through this because the team asked me to speak a little bit about HDR UK because we're trying to do this for the United Kingdom. Basically, it's to bring those skills together at scale to support research and innovation for a population of up to 65 million people. Next slide. And what we're trying to do is unite the UK's health data in a trustworthy way to make discoveries that improve patients' lives. And if we can help you, phone me up, okay? It's as simple as that. Next slide. If we tried to do this from a university, it wouldn't work, so we've set up we're in the Wellcome Trust, just down the road. We're very lean, but we're trying to create health data science ecosystems across the UK. And the thing is, we don't want to control any data, we want to support people who need to use data at scale. It's early days, we've got about £120 million. Next slide. Strategic aims, I'll canter through this. We're doing science, we're doing training, we're building an infrastructure, all built upon public engagement and trust, working with our own public advisory board and many others as we position the UK in a competitive way. Next slide. And if we do that right, we can help to support enabling infrastructure for the stuff you want to do, whether it's scientific discovery, clinical research, earlier diagnosis, therapeutics, technologies. Next slide. And these are our sites across the UK, gap in the north and the southwest, which we're addressing. Next slide. We've got great leadership across the patch. Next slide. We've got great teams across the UK, and what we're really trying to do is gear up, working with the AHSNs, working with NHS England and others to deliver value. Next slide. And what I'm keen on is breathing the same air. And I would ask the innovators, where are you innovating from? Are you innovating from a place where you bump into people over the coffee pot to share ideas? Because you need to. Because it's that chemistry of disciplines which will actually give you a better innovation. Next slide. So these are the things we're focusing on: trials, applied health analytics, public health and cancer. Next slide. Training's a big thing for us. Next slide. I'll just go through this very quickly, led by David Jones, NIHR, and our own team. And lastly, digital innovation hubs. So we've been given £40 million to actually build centres of excellence which will actually create these melting pots of innovation for digital technologies. Next slide. And that's part of the industrial strategy. So I'll finish there because of time, but just to conclude, I think you've got a huge opportunity. Make the most of your alumni network. You'll make friends on this program for life, which is terrific. And be bold, be ambitious, be enterprising, and I'm sure that when I'm invited back in 10 years, if I am, we'll have at least one unicorn in the room. So who's it going to be? So thank you very much.
Extraordinary opportunities and challenges as well. And I think one thing that will resonate with the new fellows and many of us today is the things you were talking about, interoperability and some of the practical details. You know, the NHS is getting brilliant at doing some of this really, really hard stuff, serious funding behind it, but at a practical level, sometimes we have difficulty connecting up some of the USB ports and the wires and the electrical plugs. So, you know, hugely interesting insights there. Thank you very much.